So the clinical case one is a domestic short-haired cat, a male castrated living in a urban colony. You know, these colonies of cats that they create in cities where they are more or less controlled. He has been vaccinated, and a couple of weeks ago, the caregivers detected that he was less active, and these cats are not easy to catch because they live in areas quite free, but they are under control of some people. And then when it was examined, presented some weight loss, apparently mild dehydration, and basically swelling of the foot pads. This is the cat in our hospital with some fluids, and this is the problem. This is the main problem is the swelling of the foot pads. Almost all feet were affected. And if you look carefully, the swelling is mainly on the central, on the tarsal or carpal part here, not on the digital parts. Yeah. So what will be your differential diagnosis in this case? Any suggestion? When you see that, what do you think? A bacterial infection? Exactly. This is probably your number one diagnosis, and Maria knows it very well. And it's because it's a classic presentation of cats that you should recognize when you see that. It's what we call a plasma cell polydermatitis. It's a very, not very common, but quite common presentation in these cats. And it could be an infection, but it's uncommon to have infection in all foot pads at the same time. And this is, it's very typical that this is the central part that is affected and swollen. And what will be your approach to this patient? So usually what we do in these cats is we do a fine needle aspirate to double check that there are plasma cells. If you have doubts, you go to a biopsy. In many cases, I do not biopsy this cat because the presentation is so typical that just with an aspirate looking at the plasma cells, you make a diagnosis. I also do a FIV test because about 1/3 of these cats are FIV positive, and this cat was living in an urban colony, so it's better to double check that it's not positive. So these are typically cats of middle age, so between 1 and 4 or 5 years typically affected. The pads are really swollen, and in some cases they become ulcerated. And most of these cats present to you because lameness. So the first thing that the owner sees is that the cat is lame, is limpy. Some at the beginning presented phenopathy and pyrexia, and it's quite typical also on the if you do a CBC and chemistry to detect some neutrophilia. So this is another cat with the same, with much more ulcerated foot pad. But again, you see that this is the central part that is affected. This cat is doing a common presentation of this. They try to protect the feet. You see the affected foot. That's a very common. If you do an aspirate of this with a fine needle, you aspirate this, you will see this. Many plasma cells. And we know there is a pathologist here in the room. We know that these are plasma cells because you look carefully. There's a round cell, pretty big, with a lateralized nuclei, with a very basophilic cytoplasm, with a pale area around the nucleus that is the Golgi complex, so you probably recognize that one. It's a plasma cell. So it's a very easy diagnosis if you know the entity. So what is the treatment? We know what it is, but we need to treat this cat. What are we going to do? I see Anna Maria smiling and saying, no, I know what to do. What would be your recommendation? Any suggestion? What are we going to do with this cat? This poor cat? What? Don't be shy. I'm sure you will do something. If I was the owner, you would recommend something. Usually there are 2 or 3 approaches to that. So in most of the cases, there's another disease, another one. It's a very common disease. We see one of these cats every 3-4 weeks, and they have always these swollen foot pads. This one with some scoriation, so it's very typical. So in most of the cases, what you do is you begin with doxycycline. So doxycycline, you know, it's an antibiotic, but it's also immunomodulatory, and in about 60% of cats do well. So you use this 10 milligram per kg every day. It's not very fast. They do not heal in 2 weeks. You need time. It usually takes 2 months to improve. But this is usually my first treatment. Remember that doxycycline can create esophagitis, so you need to be sure that if you use a tablet or a capsule, it doesn't remain in the esophagus of the cat, so there are some cases reported of esophagitis due to doxycycline. And if you don't have good success with doxycycline, there are alternatives. So you can use steroids and you can use cyclosporine. I usually begin with doxycycline and change to cyclosporine if the cat is not improving. Good. So cat number 1, half solved. So treatment can be improved. Cat number 2 is a Persian cat. It's another very common condition in cats that you should visually recognize. So these are diseases that you can, all the diseases that they have picked in cats, you have to diagnose just clinically. They are not very complex diseases. It's just seeing the condition saying, this is this. No doubt. So cat number 2 is a Persian cat, 3 years old, spayed female. And the history and the problem is a progressive accumulation of keratinose, brownish discharge around the facial skin, especially around the eyes and in the facial folds. The owners have been cleaning with chlorhexidine, which is what the GP suggested, to use chlorhexidine solution to clean that, also to use pads with chlorhexidine to remove the secretion, but it's not improving. No pain, no other clinical signs. Cat is happy Persian cat, ignores that he has a dirty face. It's full of accumulation around the eyes, on the folds. This is the problem. This is just this ceruminous discharge. What will be your differential diagnosis on this cat? This is also a very typical disease. When you see this in a Persian cat, probably you know that you have to put as number 1 this facial dermatitis of Persian cats, also called dirty face. The breeders of Persian and Himalayan cats call to this condition dirty face. It could be also a malassezia overgrowth. Some cats present this growth in the facial fold. It could be a pyoderma of the facial fold. That's also a possibility. You need to do a cytology to rule out this, but very typically, being a young Persian cat, this is what we call the facial dermatitis of Persian cats. It's a seborrheic dermatitis affecting the facial folds. The etiology is unknown. We don't know why these cats present this over-secretion of ceruminous material and this inflammation, in some cases with secondary malassezia overgrowth. And we know that they are initially not too itchy, but with time they become more and more itchy. So in some cats, in a publication 7 out of 13, they present also ceruminous otitis. So that is something with the ceruminous and sebaceous secretion in these cats, probably a genetic condition. And the disease is visually distinctive, meaning that you have to recognize this just clinically. It's a diagnosis that you can do just seeing the disease. You can, if you have doubts, to do a biopsy and send to your pathologist. And there are typical changes in the skin, hyperplastic dermatitis, spongitic dermatitis with some eosinophils, but usually I don't do this. I just make a diagnosis visually. with the cytology. So my question is now, what are you going to do with this cat? Any idea? Here you have another one with the same problem, milder form, another Persian cat. You see this, how is accumulating this stuff here around the eyes. So the treatment is challenging because you need to be quite persistent. If there is malassezia overgrowth, you treat that with the wipes. We did already in this cat and still had a lot of discharge, so the owner were not happy. So the next step usually is to use tacrolimus topically. You have tacrolimus here?
Yes.
For topic? Yes, you have. So this is probably the best approach to treat this cat. To apply topically tacrolimus. It's Protopic is the brand name. If this doesn't work, then you need to move to cyclosporine orally, and they do very well. This is the one cat affected with this, and you see that ceruminous-otitis, the same cat, and this is the same cat after the treatment. So they do relatively well after the tacrolimus topically. You can apply this only once a day, and it's pretty easy. Cat number 3. These are all diseases that you should recognize visually. No magnetic resonance or sophisticated, just your clinical diagnosis. This was Bagheera. Bagheera was a very old cat, well, relatively old cat. This is an American cat. The other one was from Barcelona. This is from Boston. Bagheera was in Boston. It's 13. It's a spayed female. And it's coming to see me because of the development of 2 problems, more or less simultaneously. The first one is that has an inflammation of the nails, of the nail bed, of the claw bed that you will see. Really ugly inflammation. The other one is that more recently, so first started with inflammation, you will see that, of the nails. And then, 2 or 3 weeks later, develop a nodule on the nose, here, on the lip. So the vet gave an injection of convenia, tefovecin, and a beta-lactamic antibiotic, and repeated in 2 weeks, and the nails remain bad. You'll see how is this. See how inflamed it is, and then you see that. Horrible, painful, despite the antibiotic. And not only this is not improving after 4 weeks of antibiotic, you see that the nail bed is almost destroyed. It's another, but they developed this nodule on the lip. So things are becoming worse after the treatment, it seems. You see the nodule here on the lip. Wow. What can we do? What do you think what this could be? What? It could be a pemphigus foliaceus. Pemphigus foliaceus in cats sometimes target the claws. The nodule cannot be explained by pemphigus. There must be another thing. Could be that by coincidence it's developing 2 different things at the same time. A pemphigus, rare because it's only on the claws, could be the beginning of PF. Cat is a little bit too old, but that's okay. It could be. You know, pemphigus is a disease of the middle age, and the nodule could be a different thing. Neoplasia. It's an old cat. It could be a muscle tumor. It can be a muscle tumor infiltrating the toes and developing here. That's a good hypothesis. I like it. What else? It could be eosinophilic granuloma. This is not the typical lesion that we see in eosinophilic granuloma, but it could be. Yeah, these are different possibilities. Could be neoplasia, could be an infection, different types of neoplasia. To me, the most likely possibility is this, is a feline long digit syndrome. Because in most cases, when you see this severe destruction of the nails, this is a metastasis of a tumor, and usually it's a lung tumor in cats. So this is a syndrome that has been well diagnosed in cats. Of course, we don't know at this time. We need to do a biopsy. We need to do cultures to see if there is a bacterial infection of the nail that could be resistant to convenia. Why not? In the infection of the nails, usually, if you do in cultures, you will see that in most of the cases there are mixed infections. There are staph and Escherichia coli and proteus, there are many things. It could be this resistant. So we decided to do biopsy and histopathology. We decided to do cultures. We also suggested to do an X-ray of the thorax because of the possibility of a lung tumor. This is the biopsy of the toe. It's not nice to biopsy at all of a cat, but we have to do in some cases because we had, getting the differential diagnosis, very severe diseases like neoplasia, some tumor, lymphoma, pulmonary carcinoma. So here you see it's a small biopsy, a small piece, it's a 4 millimeters punch biopsy. And you see clearly that this is the epidermis, this is a follicle, hair follicle, this is a sweat gland. And you see here there's a metastatic nodule with these horrible cells that are neoplastic carcinomatous cells. Your pathologists will see clearly that this is a metastasis of a carcinoma in the digit. And then the X-ray detected a mass here, probably different other points of the parts of the lungs. And this is very well documented in cats. So this is number one differential diagnosis of lesions in the toes. It's called feline long digit syndrome. And we know that some tumors, this was an adenocarcinoma of the bronchial tree, we don't know why, tend to metastasize in the toes. So they begin with metastasis in the toes. Then they can develop metastasis in other parts. So the nodule was also a skin metastasis of this bronchial tumor. But this is pretty common. And this is only a disease of cats. We don't see this in humans or in dogs. Only cats have this very special pattern of metastasis to the toes. Case number 4, another classic presentation of cats, very typical disease. It's a European young cat, 1 year old, with a severe ulcerative lesion on the nose. The cat was diagnosed as an eosinophilic granuloma based on cytology and eosinophilia, and has been treated with antibiotic and prednisolone, and the cat is not improving. It's really bad. So it comes to our hospital because it has an eosinophilic granuloma on the nose, which is even worse than at the beginning. So horrible. See the poor cat. Horrible lesion on the nose. Oh my gosh. Cat is not happy. It's only this lesion in the nose, but really severe. Very necrotizing with a lot of crusting in the middle. Apart from that, your patient is doing well. Only this small problem in the nose. So what will be your differential diagnosis? Squamous cell carcinoma, could be, it's a young cat and it's not white, but it could be, what else? A mycotic disease, a mycotic infection, that's a possibility too. Which one? Do you think cryptococcosis, for instance? You have cryptococcus here?
Where does the cat live? In what area or what?
It's living in an urban area. This one was living in Barcelona, downtown.
No blastomycosis?
No blastomycosis, not an American cat. This one is from Europe. So there are many different cells in this one, but a very typical one is herpes virus infection in cats that causes this necrotizing. It can be other diseases or infections, neoplasia, but a very typical problem with cats with necrotizing lesions on the face is herpes virus 1 infection. So we started to do things in this cat, and the problem with this infection in cats is that it causes eosinophilia in blood and in tissue. So many GPs misdiagnose herpes virus infection with eosinophilic granuloma because they see eosinophilia on the blood, they see eosinophilia on the biopsy or in the cytology, and they think, well, this is eosinophilic granuloma complex. And they treat with the steroids, and it becomes worse, much worse, because you suppress the immune response against the herpes virus. And this was clean, the chemistry of this. And what we have to do is to take a biopsy and try to identify lesions of herpes virus. So we did that. Very important. The biopsy is a very useful technique, but you need to select adequately the sample. So if you go and biopsy here, you will never get a diagnosis. You will send to the pathologist, and they will answer you eosinophilic inflammation with necrosis and inflammatory cells. Will say, oh my gosh, the pathologist, they don't have a clue. I send biopsies. It's your fault. You are not selecting the adequate sample. Herpes virus replicates only on the epidermis. If you don't take a sample with epidermis, you will never get a diagnosis. So we clean this a little bit, we sedate the cat, we collect the sample from this area. This is all biopsy. You see that there is a hyperplastic epidermis. There is a mildly ulcerated area here, but we have a lot of epidermis to examine. And then when you look carefully in the epidermis, there's a lot of inflammation here. We're not interested in that. You see here the inclusion bodies, or suspected inclusion bodies in the epithelial cells. So we start to suspect, well, this looks like herpes virus infection. What you can ask the pathologist to do is simply to stain this with an antibody against herpes virus to see if really these are inclusion bodies. This, for instance, or this one. So what you do is you use an antibody against herpes virus and you see how many positive cells are. So in fact, many of the epidermal cells are infected and full with herpes virus inclusion bodies when you use a specific antibody. So we diagnose an FID, ulcerative dermatitis, based on the histopath and on the immunohistochemistry for herpes virus, and we started a treatment which is classically famciclovir, an antiviral that works pretty well until you see the cat. Of course, the antiviral treatment do not repair the necrosis. So if there was a severe necrosis, we stop the problem, and then you need to do some surgery to close that. It's sad, but this cat has been too long before a diagnosis. And this is one of at least in Barcelona, one difference between Europe and the US is that in Europe, or at least in Barcelona, many practitioners have a patient and try to treat till they are desperate. And then when it's like this, they say, okay, go to see an oncologist or a specialist. And then they say, the oncologist see the patient, or the dermatologist or ophthalmologist say, now we cannot do anything. And then the GP says, okay, even the oncologist could not do that. It's your fault. If you send the patient at the beginning, as the Americans do, then you can treat this cat and avoid this necrosis. If you wait till you have treated with 20 different things, till you say, I don't know what it is, so we have to send to a specialist, then probably the disease is too advanced to have a good control. In the US, they do it in a different way. Do you see a cat like this? I don't know what it is. I will send it first to a dermatologist. We will share the case, and I will continue with the treatment. But I want to know from the beginning, what is this? And to have someone in my team that is an expert neurologist or ophthalmologist or dermatologist. I want to continue treating the case, but I prefer to know from the beginning what is this and if I'm doing something wrong. In Europe, this culture is not well developed, and many general practitioners think that I will try to fix this eye till I cannot. And then I will consider, well, maybe there's someone that knows more than me about eyes. Then I refer the case when the eye is completely lost. So we skip that. So this is a very well-known disease. I do not have too much time to talk about that. In most of the cases, this infection do not cause this necrotizing dermatitis. In most of the cases, when the cats are infected with the virus, they develop acute respiratory disease. You know better than me. But it's true that there are some cases where the virus remains in the trigeminal ganglion and can be activated and then causes the dermatitis. Skip that. So just to show you one example of the same disease where the biopsy was not well taken. This is another cat with the same condition. This was seen by another practitioner in the US. And it's a ragdoll cat, female non-spayed, with a severe ulcer on the nose, more or less the same. You will show mild submandibular lymphadenopathy. The cat has been treated with antibiotic and steroids without success. You see the lesion here. You see now you recognize that this is a very quite typical pattern. The cat was biopsied on this area. This is the biopsy of this cat. You see this biopsy was done by the practitioner. And this, the biopsy that the cat was not doing well was sent to me. And you see epidermis on this biopsy? No. We are not going to find anything here. Just inflammation, eosinophils. Yeah, we see many eosinophils, but we are not going to do that. And we work a lot on this cat. So we did immunohistochemistry, was also negative. We did a PCR to detect herpes virus, negative. You cannot fix. If the sample is not good, you can work a lot on that. You will never have a good diagnosis. So it's very important that you select well the sample because you cannot fix a mistake done at the beginning of the process. And we never got a good diagnosis. I'm sure that this is a case of herpes virus infection, but I could not find the virus because the sample was not good, and the owners didn't want to repeat the biopsy. Saying, we did already one, we have done tons of things, PCR, immunohistochemistry, we have spent a couple of thousand of euros, don't want to do anything else, we did some treatment with lysine just to help a little bit, and that's it. So, selecting the biopsy site is very important. Doing biopsies, it's very useful, extremely useful. It's the most important technique that you can use for diagnosing skin diseases. But you need to select very well the sample. You need to spend some time looking for carefully and then selecting a good sample. So if you have primary lesions like pustules or vesicles, you have to take one of them. If you have an ulcer, remember that you cannot go in the middle of the ulcer with a cross because this is not going to be helpful. You need to go to an area with epidermis. If you have alopecia, on the contrary, we usually go to the most old and advanced area of alopecia because the lesions are more advanced. So there are some rules to get the biopsy. So we simply can go and punch deep side, put in formalin and send to the lab. And also the pathologists need to have full information of that. So if you want that this technique helps you, you need to do this properly. If not, you will feel that it's not very, very useful.